Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Lucia Yumena, MD. Dr. Lucia Yumena is an internist and nephrologist. Dr. Yumena attended the University of Santo Tomas and graduated magna cum laude. She attended medical school at the University of the Philippines, Philippines General Hospital. She received her internal medicine degree at USC in Southern California, and Dr. Yumena received her nephrology training at San Francisco General Hospital, UCSF, and VA San Francisco. Dr. Yumena is on staff at the Washington Hospital Healthcare System.
We're going to talk about kidney disease in reference to diabetes. So we'll talk about the risk, management, and beyond. I've shown this slide before to other attendees, but for those who are new here, I always like to show this slide on the anatomy or how the kidneys look like. The two structures which are bean-shaped are our kidneys. We have one on each side of our flanks. And the structures there, the blue structure is the vein, and the long tubular structure right in the middle is the big blood vessel called the aorta, which supplies the major blood to both kidneys and throughout our body. Now, the white tubes that go down are called the ureters, which drain the urine, and it drains the urine into the bladder before it's finally emptied outside of the body. This is what the kidney looks inside. On the outer portion is what we call the cortex. It has 1 million glomeruli on each kidney. So we have 2 million glomeruli. Glomeruli means the functioning unit of the kidney, which filters the blood. These are our learning goals tonight. I want to show you how the kidneys get damaged in diabetes mellitus, and I'll show you the clinical staging in chronic kidney disease, and we'll explain to you the risks of developing diabetic kidney disease and the risks when one has diabetic kidney disease and the treatment of diabetic kidney disease. So in the subsequent slides, you'll probably just see CKD and DKD. Diabetes is now considered the #1 cause of kidney failure throughout the world. And the major number of patients going into dialysis are mostly diabetic patients. And 95% of those are type 2 diabetes. Type 1 diabetics comprise 6% of those who end up on dialysis. Now, kidney injury in diabetes mellitus occurs in the structure, the glomeruli, and the tubules. I'll show you in the subsequent slides. The high blood glucose or hyperglycemia triggers growth factors which we have in our blood. So we have more growth factors which then cause the glomeruli to enlarge. There's also a condition we call hyperfiltration, where the kidneys filter or work more than they are supposed to, and we call that hyperfiltration. It's not good because it burns out the kidneys. So the kidneys in a diabetic patient with involvement of diabetes in the kidneys show large kidneys and large glomeruli. And the end stage is called sclerosis, which is a medical term for scar tissue. So this is the picture of a normal glomerulus. But what happens in diabetes, this glomerulus grows bigger. We don't have more glomeruli. We have a fixed number of 1 million per kidney. So what happens is each glomerulus gets bigger, and that's why the kidneys get bigger. But eventually, what happens is this glomerulus, which looks very clean and clear, becomes transformed into this kind of picture. We call this diabetic glomerulosclerosis. You see how much change you see in diabetic kidney disease. It's hard for blood to be filtered through this structure. And even if it looks like this, the blood does not get filtered well, but protein leaks. And when we see protein leaking in the urine, it's abnormal. We shouldn't see protein, which we always term albumin or microalbumin, in the urine. So when you get a urinalysis and it shows protein, that's abnormal. Microalbumin, albumin is the same as protein. Now when we say microalbumin, it doesn't mean that the protein is tiny. It means lesser in amount. On the other hand, macroalbumin means there's more albumin. So it's a misnomer. When we say microalbumin, you would think it's tiny, but it's not. It's just the amount. That's why they call it microalbumin. So let's define chronic kidney disease. It's when the kidneys gradually lose their function over time. And we say 3 months at least, longer than 3 months. In contrast to acute kidney disease, which can happen suddenly, like for instance, victims of trauma or war, where they had previously normal kidneys and then suddenly they develop acute kidney disease where their kidneys fail. So for chronic kidney disease, patients may not even know they have chronic kidney disease. So they have to have had loss of function gradually longer than 3 months. The second criterion is increased microalbumin in the urine. Normally, there should not be any microalbumin, but we allow as much as 30 micrograms in the urine. There should be a major decrease in kidney function. And we measure kidney function by the estimated test called eGFR. We'll discuss that in the next slide. And you'll see that in your lab results when you go to your doctors. So microalbumin is a protein which leaks into the urine when the kidney is damaged. It is easily tested on a single urine sample. The best single urine sample should be the first voided morning specimen. So first morning voided specimen. It's a very sensitive early sign of kidney disease. And it is a very sensitive reflection of cardiovascular risk. So it doesn't only indicate that there's damage in the kidneys, but if one has microalbumin and the rest of the kidney test is normal, it is a hint that one is at risk of heart disease or peripheral vascular disease or stroke. So microalbumin is an important test. Now here we go to eGFR. It stands for estimated glomerular filtration rate. It is the best estimate of kidney function we have so far. In the academic setting, there are more tests which are more accurate than eGFR, but for all practical purposes, this is what we use in the clinical setting. It is almost as good as doing a collected 24-hour collected sample. It has to be interpreted properly, though. So when one has eGFR of below 60 or above 60 or 80, 90, you need to go over that with your physician. I'll explain that later on the subsequent slides. It is easily estimated from a simple blood test, and normal is around 100 for a young person. So we go to the stages of chronic kidney disease. Stage 1 is the earliest stage of chronic kidney disease. Stage 5 is the worst stage of chronic kidney disease. So we go by the percentage of remaining function as estimated by GFR. So in stage 1, there is protein in the urine or microalbumin, but the estimated glomerular filtration rate or the percentage of the kidney function is greater than 90%. And that's pretty good. So most patients in this stage don't know that they have chronic kidney disease unless they get this test done, the microalbumin in the urine and the eGFR. So stage 2, the GFR is between 60 to 89. This is mild chronic kidney disease. And the stage 3 is GFR of 30 to 59. So below 60, but above 30. And this is moderate chronic kidney disease. Stage 3 is really important because at this stage, some patients have a lot of cardiovascular risks, and some of them, if they don't do the right lifestyle modification, they don't take their medications, they won't progress to stage 5 because they'll die even before they reach stage 5. So for those with GFR below 60, with diabetes, patients should pay more attention in doing some lifestyle modification and taking some medications and avoiding some medications. So stage 4, GFR of 15 to 29 or 15 to 29% kidney function, this is severe. And this stage will progress to stage 5. It's a point of no return. Patients who are in stage 4 will eventually end up on dialysis. We have medications, though, to delay that. And we do have some patients who stay at stage 4 and takes a long time to end up on dialysis because they try really hard to take care of themselves. So stage 5, this is when the percentage of kidney function is less than 15% or the GFR is less than 15. This is what we call a kidney failure. And at this stage, we discuss it with the patients and their families, what the options available are, which is dialysis or transplantation or no treatment. So what are the risks for developing diabetic kidney disease? The longer one has had the diagnosis of diabetes, the higher the risk of developing diabetic kidney disease. So if one has been diagnosed to have diabetes only for 3 years versus another one who has had diabetes for 15 years or 20 years, who do you think would have the higher risk of developing diabetic kidney disease? Of course, the one who has had diabetes for 15 years or 20 years. So I put that high on the list because that's a really high risk for developing diabetic kidney disease. Now, poor control of blood glucose, poor glycemic control, as your dietitian and your diabetes nurse will tell you, that is also proven to be a high risk for diabetic kidney disease. It's proven that if your blood glucose is always uncontrolled, your chance of developing diabetic kidney disease is high. High blood pressure or hypertension, that's a high risk for diabetic kidney disease. And protein leak in the urine or microalbumin in the urine, that's a sign that there's already diabetic kidney disease. However, if one does not have microalbumin in the urine, it does not completely eliminate the presence of diabetic kidney disease, especially in type 2. So its presence confirms that something is really wrong with the kidneys. But the absence should not make us feel secure that we don't need to worry. We still have to work on trying to keep our kidneys healthy, trying to control our diabetes, okay? The last item here, but on the subsequent pages, I'll show you more risk factors of diabetic kidney disease, is retinopathy. So every diabetic patient should see an ophthalmologist or an eye doctor and have the retina examined. This correlates or has a really accurate relationship with diabetic kidney disease, especially in type 1. So if there's retinopathy, very, very high chance of nephropathy or diabetic kidney disease is present. So sometimes what we do when we're in doubt, we tell a patient, we're not sure you have diabetic kidney disease, but go see the eye doctor. And if he tells us there's retinopathy, then we say, okay, it's diabetic kidney disease. These are other risks for diabetic kidney disease. Race. African Americans have the highest risk, followed by the American Indians or the Native Americans, and then the Hispanics, and the Caucasians the least. So it has some race predisposition. And genes, genetic susceptibility. There are studies on genes, family history, ongoing. There's a correlation between people who have diabetes and diabetic kidney disease and their children or their siblings developing diabetic kidney disease. So this is important. For instance, patients who have family members on dialysis and they're diabetics, they should really, be checked. Advanced age, those who are above 65 or 70 or 80, the older one is, the greater the risk of diabetic kidney disease and worsening or progression to stage 4 or 5. Male gender, unfortunately, being male does not give you any advantage. So being female gives them a gender advantage. Now, high blood uric acid. Who would think that uric acid is important in kidney disease? So it has been shown that those with kidney disease and diabetes, if the uric acid is high, this patient will have predictably a greater risk of progressing to stage 4 or stage 5. It's also correlated to higher cardiovascular risk, which means higher risk of heart attack or stroke. So high uric acid is important. So that's another blood test. Bladder nerve damage is not a risk for developing diabetic kidney disease, but if the bladder nerve is damaged because of uncontrolled diabetes, the bladder does not contract well, does not empty, so the pressure in the bladder backs up into the kidneys and the kidneys get swollen, and so the kidneys get damaged. Women also who have frequent bladder infection may be due to bladder nerve damage. So frequent urinary tract infections, which go up into the kidneys, we call pyelonephritis, can also cause scar tissue. Maybe 30, 40, 50 years ago, nephrologists thought that pyelonephritis did not cause kidney failure, but now we know that this problem can also contribute to worsening of the kidney function and kidney damage. Obesity in a diabetic patient can worsen the diabetic kidney disease. Obesity itself is an inflammatory state. It causes inflammation. Inflammation is not the same as infection, but inflammation is a condition where I could give you an analogy. For instance, you fall and your knee gets swollen and red. That's inflammation. So inflammation can occur throughout the body and in the kidneys in obese patients. Exercise we encourage because exercise helps prevent inflammation. Smoking. Smoking and obesity, in some patients who have been biopsied, their kidneys have been biopsied because we were not sure what was going on. They didn't have diabetes. But it showed a picture in the glomeruli that's similar to diabetes. The kidneys also grow. And it has a lot of scar tissue too, just like diabetes. So it's a bad combination: diabetes, high blood pressure, high uric acid, obesity, smoking. And I mentioned kidney stones. High blood uric acid can cause kidney stones, and it's called uric acid stone. That's the kind of kidney stone that we see in diabetic patients. Kidney stones are not good because they can cause blockage in the flow of urine. And so if the urine doesn't flow, it can damage that kidney too. So we want patients to drink more water and avoid a lot of red meat because that contributes to, red meat contributes to high uric acid. Now, what are the tests that we use to detect diabetic kidney disease? So you're familiar with the urine microalbumin now, which I discussed earlier, and the eGFR, or the blood creatinine. And the kidney ultrasound is well, let me go back to urine microalbumin, or ACR. In my previous lectures, I said urine microalbumin. But nowadays, the studies show that albumin to creatinine ratio is more accurate than urine microalbumin. So this is the test that I would order. It's not generally available in all the lab slips. For instance, in Washington lab, it's not there, so I have to write it down there. But in other labs, it's available. So we write UACR. It's not as variable as urine microalbumin. It doesn't change as much as the urine microalbumin. But it's basically the ratio of the albumin or microalbumin to the creatinine. So creatinine is eliminated in the blood. It's eliminated in the urine. It's in the blood and in the urine. It's a waste product. It's a waste product that our body generates from the protein we eat. It's also released by the muscle. So it circulates in the blood. It's called creatinine. It's a waste. We don't want creatinine building up in our blood. So when it goes through the kidneys, it should be eliminated in the urine. So we do the ratio of the albumin to creatinine. And normal should be below 30. So if it's above 30, it's microalbuminuria, between 30 to 300. If it's above 300, that's really quite a lot of albumin. That's already called macroalbuminuria. So if it's 300 and above, that's pretty obvious. There's no doubt there's diabetic kidney disease. Sometimes if it's 30, 29, 31, we wonder if it's real. So what we do is we do it again 2 times within 3 months. So we do another urine test for 2 more times, and we should get 2 abnormal results out of 3 before we tell that patient, oh, you really have protein leak in the urine. You really have microalbuminuria. So 1 test is not enough. We have to do it 2 or 3 times within 3 months. So kidney ultrasound, that's an X-ray procedure. It doesn't cause radiation, but it's a very good test to see if the kidneys are, if one has 2 kidneys and they're equal in size, if there's any cancer, if there's swelling or blockage, or one is smaller than the other kidney. If one is smaller than the other kidney, then we worry about that kidney, the small one, losing function or shrinking. And it could be because it doesn't have enough nutrition, not enough blood supply. So it's really beneficial to have a kidney ultrasound. Rarely, although it's the standard, the gold standard in diagnosing any kidney disease, rarely we do a kidney biopsy when we are in doubt if it's due to diabetes. So here are the findings wherein we begin to doubt if it's diabetic kidney disease. It is unlikely diabetic kidney disease that we're dealing with if a patient has a rapid decrease in kidney function. Okay. It's not gradual. Suddenly you have a patient who had good kidney function for many years that they've been followed up, and then all of a sudden they come in and it's really dropped fast. Also a rapid increase in microalbuminuria or proteinuria. The presence of blood in the urine. It doesn't necessarily have to be seen by the eyes. It can be detected under the microscope. Typically in diabetic kidney disease, there's no blood in the urine, although sometimes we see it and it's diabetic kidney disease. Resistant hypertension or resistant high blood pressure. We label one as having resistant high blood pressure if they're on 3 or 4 or 5 blood pressure medications, and they're really taking their blood pressure medications, they're compliant, and they're watching their diet, they're not consuming a high sodium diet, and yet their blood pressure is so out of control. It stays like 180, 190, 200, and they're on 4 or 5 medications. That's what we call resistant hypertension. If there's a large decrease in the eGFR, we talked about that, the percentage of kidney function, after that patient has been started on a medication which is an ACE inhibitor or angiotensin receptor blocker. These are 2 groups of medications that we use for patients with diabetes with high blood pressure to preserve their kidney function. So if these conditions are present, then one would consider a kidney biopsy. Now, why is it important to detect diabetic kidney disease in its early stages? It is important to do that to prevent, because we know that there are measures that we can do to prevent progression. So we can delay the progression or the worsening to end-stage kidney disease. Control of blood pressure and blood glucose is really important, necessary. I cannot really emphasize that so much. I've mentioned it repeatedly. And it's because I'm trying to reinforce that these are the 2 important things, blood pressure and blood glucose control. Now, certain medications can protect the kidneys. So if we detect that there's microalbuminuria and there's a drop in eGFR, that's early detection. We know we can intervene or we can do some measures. We have some strategies to protect the kidneys and to prevent the risks associated with diabetic kidney disease. Mortality means death, the risk of dying in diabetic kidney disease. a type 1 diabetic with microalbuminuria, the risk of death is 3 times compared to one who doesn't have microalbuminuria. So microalbuminuria is 30 to 300 of micrograms of urine. Now, if that type 1 diabetic has macroalbuminuria, which could be 300 or 400 or 1,000 or 3,000 of microalbumin in the urine, the risk of death triples. It's 9 times. So there's a correlation between the amount of microalbumin in the urine and dying. So there's also a higher risk of death when the eGFR is below 60 in a type 1 diabetic. But look, a high GFR doesn't mean the patient is going to do well. So eGFR that's above 120 in a type 1 diabetic also means high risk of death. In type 2 diabetics, the risk of dying is greatest in stage 4 or stage 5. That means GFR that's less than 30. The presence of protein in the urine. The more protein in the urine, the greater the risk of dying. Congestive heart failure. A diabetic patient with congestive heart failure, there's a higher risk of dying. And vascular disease, which could mean peripheral arterial disease, which means blockage in the arteries in the legs or in the neck or in the arteries that supply the kidneys. That's associated with higher risk of dying. Now, in dialysis patients, it's surprisingly that if their cholesterol is low, it means they have a higher risk of dying. So we don't really push our dialysis patients to be strict with their diet, because the lower their cholesterol, we found out that if their cholesterol is low, they have a higher risk of dying because they're so malnourished. They die from other causes, not the low cholesterol. Now, how do we manage diabetic kidney disease? Again, control blood glucose and control blood pressure, control cholesterol or lipids. Lipids has the bad cholesterol, the good cholesterol, and the triglycerides. Reduce the microalbumin or protein in the urine with medication, and exercise, 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 exercise. Diet and quit smoking. Drugs like Advil, Motrin, Aleve, ibuprofen should be avoided. And it's important that the diabetic patient with diabetic kidney disease should see the doctor, preferably the nephrologist, a diabetic educator, and dietitian. It's hard to learn how to manage this by just going online on the internet. One has to really meet face-to-face with the diabetes educator and dietitian to tailor the treatment to each patient. Okay, when we say control the blood pressure, this is our goal in diabetic kidney disease. Between 120 to 130 systolic, over 70 to 80. If we drop it to 90 over 50, it may cause a stroke in an elderly patient. Okay, if it goes up to 140, 150, 160, 170 over 90, 100, it causes more damage to the blood vessels. It makes the heart work harder. It makes the damage in the blood vessels inside the kidneys get worse. So from studies, it has been shown that this is the good range, between 120 to 130 over 70 to 80. But then we also need to individualize this. So this is like a guideline, but not a hard and fast rule. For a 90-year-old perhaps, or an 80 years old, this may be too low for them. So we always need the guidance of a physician. A first-line drug should be an ACE inhibitor or an angiotensin receptor blocker, because this affects the hormone system that affects the blood vessels in circulation inside the kidneys. So an ACE inhibitors would be something like lisinopril, benazepril, captopril, enalapril. And these drugs have been around since the early 80s. And angiotensin receptor blockers are losartan, which is now generic, and the others are still brand name, like Diovan, Mycardis. So the generics are reasonable. It doesn't mean that because you're taking a brand name it's superior to the generic. So these are the first-line drug that should be used in a diabetic kidney disease with hypertension. Not amlodipine, not diltiazem, not a diuretic. Those drugs are not the first-line drug of choice for controlling blood pressure in a patient with diabetic kidney disease. Oftentimes, patients with diabetic kidney disease may require multiple blood pressure medications. It may not be enough to use one drug. They may require additional diuretic, additional calcium channel blocker, but this should be the number one choice to protect the kidneys from getting worse. Okay, the next point we need to make here is lowering of albuminuria or proteinuria. It has been shown that if one has tight glycemic control or well-controlled blood glucose, well-controlled blood pressure, and cholesterol, this control of blood glucose, cholesterol, and blood pressure help lower proteinuria independent of using those drugs, but probably not enough. So ACE inhibitors or angiotensin receptor blockers are recommended. Now, how do we lower lipids or cholesterol? Of course, low cholesterol diet. One cannot assume that if they take medications, they can eat anything. Of course not. One has to follow the low cholesterol diet. And if that doesn't work, medication should be added. However, in a diabetic kidney disease patient, the American Diabetes Association recommend that they should be put on statins. Statins are, you're probably aware of this, they're lovastatin, pravastatin, atorvastatin, this simvastatin. These are 4 generics, and there's another one, I forgot, fluvastatin. So we have so many generic statins now. The potent ones are atorvastatin and simvastatin. Studies, simvastatin has a lot of drug-drug interactions. So if you're on simvastatin, you have to really discuss that with your physician whenever you have new medications. Because if simvastatin is combined with other drugs, which should not be given with it, it can cause kidney failure. So simvastatin, patients on that drug should really be aware that that drug may be dangerous when they take other medications along with it. Some of those are antibiotics or antifungal drugs. Statins, however, unfortunately, they do not stop worsening of chronic kidney disease. So if one is in stage 1 or stage 2 or stage 3 chronic kidney disease, it doesn't prevent the worsening of chronic kidney disease. So statins do not prevent worsening of chronic kidney disease. Why do we want statins in these patients, in diabetic patients? Because the diabetic kidney disease patient has the higher risk of dying from stroke and heart attack and gangrene of the legs. So even if statins do not stop the worsening of chronic kidney disease, it's because of the high risk of cardiovascular events or stroke, heart attack, and gangrene of the extremities or the legs. That's why we recommend statins. So again, I have to reiterate this. Diabetes is the #1 cause of kidney failure in the world. And kidney failure means the kidneys cannot perform the job of cleaning the blood or filtering the blood. And when the kidneys fail and cannot perform those functions, there are many symptoms associated with that. Loss of appetite, loss of ability to think, weakness, shortness of breath, swelling all over the body, lack of urine, and vomiting, nausea. So when a patient goes to stage 5, which means less than 15% kidney function, we offer dialysis or transplant. And there are 2 kinds of dialysis. One is through the blood, we call hemodialysis. And the other one is through the abdomen, through a compartment there called peritoneal cavity, which we call peritoneal dialysis. Now, if one is older than 45 years old, they seem to survive better if they're put on hemodialysis. 10 years ago, we thought that Peritoneal dialysis is better for the old folks because of their heart problem. They have less drop in blood pressure with peritoneal dialysis compared to hemodialysis, where there's a lot of a drop in blood pressure. But the current data show that patients who are older do better, live longer on hemodialysis than peritoneal dialysis. But if a patient has stage 5 chronic kidney disease and needs to go on dialysis, if they're less than 45 years old, they have better survival on peritoneal dialysis. So when a patient has stage 5 or stage 4 actually is the time when patients are educated so that they know long before they need the treatment what treatment they should decide to do. Kidney transplant is an option. There are a lot of criteria for kidney transplant, but it seems like they're accepting more patients, which they didn't used to do. And we have more transplant centers in the Bay Area. The wait list, of course, is long. Depends on which region a patient lives. And it varies from state to state. It looks like at UC Davis, the wait is shorter compared to the Bay Area. And comparing California to Oregon, the wait is shorter too in Oregon. The incidence of patients on dialysis is less now, but the prevalence is still high. Okay, this slide is so busy. You don't really need to read all of this, but it just tells you what's going on there in the medical world, the studies that are ongoing to help patients with diabetic kidney disease. So these are words which are difficult for you to understand, like SGLT2 inhibitors, anti-RAGE antibodies. Some of these drugs are already available. For instance, spironolactone and atrasentan. Those are available drugs. And metformin, which is a common, okay. This is available. We use that in heart failure. And that's available. We use that for high blood pressure, but it's not routinely prescribed because they can make the potassium go up. So for a patient to take this drug, they need to be followed by a nephrologist, and their potassium be watched closely, and their creatinine or blood test for kidney function should be followed closely. This is another drug that's available. It's a common drug, a generic drug that's used for diabetes, metformin. Okay. But this drug can be dangerous at a late stage because of lactic acid building up in the body, which can cause coma. It's a good drug to control diabetes, but if a patient has stage 4 chronic kidney disease, stage 5, this is contraindicated. Okay, rosiglitazone, that's Avandia, which was taken off the market. But they're still doing some studies on it because of some benefits that were seen with it, on it. Resveratrol, this is in red wine. Resveratrol has some benefits for diabetic kidney disease. And of course, calorie restriction and exercise. This one is a medication for transplant to prevent, it's an immunosuppressive drug to prevent rejection of kidney transplant. And these are experimental drugs. Anti-CTGF, anti-TGF, anti-transforming growth factor beta antibodies. In summary, early diagnosis of diabetic kidney disease is important. Diabetic kidney disease has risks and complications that can lead to kidney failure, cardiovascular disease, and death. And there are strategies to reduce the risks of diabetic kidney disease. Diabetic kidney disease with end-stage kidney disease is treated with dialysis or kidney transplantation. Thank you for your attention.